let me tell you what the literature says. Let me tell you what the body of research that's out there says about families. There is quite a significant body of literature which looks at families of people with severe brain injuries, but those that aren't in a disorder of consciousness. That body of work really talks about families being stressed, under a great deal of physical strain, having a vast range of emotional and psychological difficulties, being depressed, anxious, grieving, that we said, under financial strain because they can't work like they normally would and their loved one is no longer financially bringing in what they would have done before, experiencing a significant reduction in their leisure time, feeling lonely and very socially isolated. If we look at the research that looks at the experience of families of those who have a loved one in a disorder of consciousness, it highlights much the same, but distinctly highlights very high levels of depressive symptoms, with around a third of these families meeting the criteria for a so-called prolonged grief disorder. So that disorder refers to an emotional paradox where families are unable to mourn conventionally because the person in a disorder of consciousness, although is in many ways achievably gone, they aren't biologically dead. So research with these families also highlights guilt, frustration, anger, especially around end-of-life decision-making. If we just take a second to look at the literature more broadly, in neuro-rehab literature, families can be presented as having unrealistic expectations, being a source of conflict or challenge to the rehabilitation process, but also at the same time being critical to patients' well-being. In social care literature, families can be seen as a resource, so a provider of care, as maybe a co-worker, so someone to help monitor patients when us as practitioners aren't there, but also people who are burdened by their caring responsibilities and people in need of support. In the long-term care literature, families are frequently reported to experience guilt and depression due to being unable to look after their loved ones themselves. They can again be seen as a resource, but this time as a provider of interaction with patients or provider of information. And they can be considered as being very demanding, very time-consuming, sometimes as a source of abuse and violence, but again, critical to maintaining a patient's identity and personhood and improving the likelihood that patients will receive more personalised care. But what is it that seeing families in those ways does? What's the problem with seeing families in these ways? If we see families experience as psychological illness, like the literature says, and chucking out terms like prolonged grief disorder that needs treating, then we're pathologising, we're medicalising that experience, rather than seeing it as upset, as grief, as an entirely normal response to this situation. Pathologising their experiences might then also mean that we put their behaviours down to this psychological problem and ignore what they're actually saying, especially when they might be raising really significant areas of concern like poor care, lack of communication, excluding them from decision making, which is not only inappropriate, it's actually illegal. Seeing families as patients, so people in need of support and care, kind of does a similar thing. Considering them as people to be cared for presents us seeing them as part of the team, caring for the patient, or as a key relationship within the patient's world. So they can easily become kind of taken outside of the team and attention's turned to their individual needs, not their needs alongside the patient. So that's not to say that families don't need to be cared about, they certainly do, but just not in this kind of paternal, pathologised way. If we see family members as burdened by caring, that frames caring relationships largely as really negative and as one way, and prevents seeing the multiplicity of relationships, so how care can and does often work in two ways if we think more broadly for a moment. So patients can often still provide caring roles or hold roles within relationships, even though they are reliant on some care themselves. So the frame of burden prevents seeing resilience and flexibility in relationships and the ways that we can change our roles and adapt to situations that we're faced with. So the idea of burden frames caring as being unnatural, as a waste or a hindering of life of those caring, rather than a normal part of life and death, of family life, of community, and of humanity. Now, families can be seen as commodities, like I mentioned, as resources, as things that we can, as professionals, that we can use them for. So as time spent with patients, as information, as people to provide care. How many of us have looked at discharging a patient and been very keen on what the family can provide, because that gives us a route to discharge very quickly, or maybe more quickly than if they aren't able to provide care at home. What I think, if we see families as commodities all the time, then we do risk, I think, them being a bit abused, a bit put upon, and without their needs being attended to. And individual consequences of care then aren't considered, and we can maybe dismiss them. Okay.